So, kia ora koutou, everyone. It is great to welcome you all on a Thursday night. It's a really, really special night tonight because we've got a wonderful, wonderful guest speaker. I'm so excited to introduce you to her. It's Rachelle Steyn talking about PRRT. Look, I'm not going to spend lots of time giving your CV, but you're a nuclear medicine specialist. You've come from South Africa where you set up a PRRT service from scratch by getting connected with the right people and getting things off the ground. So you've got heaps of experience and you're now bringing that to us in New Zealand. So Rachelle, welcome and thank you so much.
Thank you very much, Michelle, for that unbelievably kind introduction. For me, of course, it's an absolute pleasure and honor to be here and also to be speaking to you this evening and to be meeting you all. I was involved in a neuroendocrine tumor support group in South Africa as well, and this brings back many memories. It's so nice to be part of a support group and to be part of the Neuroendocrine Tumor Foundation New Zealand. So thank you very much for that. But before I start, I'd just like to introduce. I know that Karen Wells is on the Zoom call today. She's very much part of the PRR team as well. She's the medical officer who's running a lot of the who's running the service with me, and Avril and Liana, who you guys probably know very well as well, are our CNSs and really are the heart of the service. And it cannot happen without them. So it's great to have Karen and Avril and Liana on with us today, and they'll probably also prompt with some questions. That'll be good. So we can get started. So basically, it's just titled the what's, the hows, and the why of PRRT, because I think it's quite a foreign concept, isn't it? You know, coming in for radiation treatment, which is localized to a tumor, and how exactly does this work, and where does it, you know, sort of from the beginning through to the end, how does it actually work? And I think we need to start with the very, very basics, and you guys probably know all of this better than I do. So what exactly is a neuroendocrine tumor? A neuroendocrine tumor is a tumor that develops from neuroendocrine cells within our body. And that's kind of what that neuroendocrine tumor cell looks like. And it's got two very special features. The one feature that it has is these little things over here, which are somatostatin receptors. And then it's also got within it hormones, so it can secrete hormones. So that's basically the makeup of a neuroendocrine tumor. And where in my body are these neuroendocrine cells found? I mean, they're found everywhere in our bodies. They're all over the place. But the most common areas where neuroendocrine tumors develop are in the thyroid. They can develop in the lungs, in the pancreas, in the stomach, in the gut, and in the adrenal glands. So those are the most common places, and it's when these tumors start growing very, very fast that a neuroendocrine tumor starts developing. So it's a group of neuroendocrine cells in a specific place that start growing abnormally, and that's when your tumor develops. Neuroendocrine tumors have got 5 very specific features, and all of these features are important when we think about PRRT and treatment strategies. And the first feature is that, and you've probably heard a lot of your oncologists say, they're heterogeneous, they're different, they're not all identical. They don't all come from exactly the same area. They secrete hormones. which hormones they secrete is very individualized to the different tumors. Some tumors secrete noradrenaline, some tumors secrete 5-hydroxy-5-HIA, they secrete chromogranin. Some tumors don't secrete any hormones at all. So that's where we talk about functional neuroendocrine tumors or non-functional neuroendocrine tumors. And it's these hormones, if you've got a functional neuroendocrine tumor, that actually creates those symptoms, the carcinoid disease, the flushing, the diarrhea. They have receptors. The majority of neuroendocrine tumors and neuroendocrine cells have somatostatin receptors. And that's why we can treat them with PRRT or image them with GAT8. The majority of these tumors grow very, very slowly. A lot of you might have had them for years, and then they get picked up quite late, and you're actually quite surprised that you've found to have a neuroendocrine tumor. Some of them grow a little bit faster, and some of them grow very fast. And it just depends what the makeup of that tumor is. And you might have a tumor which is spread in your body, and some of it grows faster than other areas. So they really are tumors which are different and behave differently in your body. And then they've got different treatment options. So they don't just fall into one category where one treatment option works. One has a choice of options, and one has to look carefully at how the tumor is made, what it's made of, to select the best type of treatment for that tumor.
Rachelle, just while you're changing slides, we had a nice little comment in the chat from Martine saying, just wanting to clarify that everyone has neuroendocrine cells, but most don't turn into tumors. Is that correct?
That is 100% correct. We all have neuroendocrine cells in our bodies, and the neuroendocrine cells actually regulate metabolism of things. And it's just some of those cells and some of the areas start growing abnormally, and that's how the tumor develops. That's correct. Do I carry on?
Thanks, Rachelle.
Okay, so PRRT, or Peptide Receptor Radionuclide Therapy. So that's the long word name for it. What exactly is it? It actually combines a treatment with an imaging. So when we think of PRRT, we can't just think treatment. We've got to think imaging as well as treatment. So these two things go hand in hand. And I'm going to go through the imaging part first, because you can't do the one without the other. You need the imaging to be able to treat. And most of you, or I'm not sure, may have already gone for a PET scan, specifically called a GAT8 PET-CT scan. So when we image, what are we looking at? Remember our picture of our cell? We have our somatostatin receptors. So we want to see how many somatostatin receptors are actually on your tumor. And that's what is going to determine whether PRRT is a good treatment option. So we need to do the imaging first. And this is basically how it works. So there's a PET scanner, and the PET scanner currently that does the gallium dotatate or GAT8 PET. So that's the name of the tracer that goes to the somatostatin receptors, is currently in Auckland at Mercy Hospital, or the Mercy Radiology Department, and they do the GAT8 PET scans. And what is GAT8 PET? I mean, what is it? How does it work? So you've got gallium, and gallium is the radioactive bit. That's the bit that gives us the picture. And then you've got dotatate, which really, that is the radioactive bit. It gives off a little radioactive gamma ray. And then you've got the dotatate, which actually loves this little somatostatin receptor and will stick to it. And if we combine the gallium with the dotatate, we can take a picture of the somatostatin receptors in your body. So this is what a gatate PET scan looks like. And remember I said we were targeting somatostatin receptors? Look where they are. There's some in your pituitary gland, there's some in your salivary glands, there's some in your thyroid. This picture's not that great. There's some in the lungs, quite a bit in the liver, spleen, kidneys, gut. So that would be a normal gatate scan. So gallium with the dotatate has got a little gamma ray, gives us a picture, and that equals our scan. And that is what we would look at to see whether we can treat your tumor with PRRT or not. So this is a normal study, and this is an example of a pancreatic tumor that has got lots of uptake. Do you see how black it is? Quite black, it's dark. So we generally like it when the tumors have got lots of somatostatin receptors where they're nice and dark. And if you compare it to the background of the liver, it looks much hotter. We call it hotter in nuclear medicine, but it's just more intense, more receptors. And this is an example of a tumor, but it has spread to the liver, it's spread to lung, and it's spread to bowel. So we can also use the gatate scan to assess where in your body the tumor is located. Okay. So how do you know that my tumor has enough somatostatin receptors for PRRT? That's a very good question. It needs to be nice and hungry for gatate. It needs to have good uptake. Look how clearly I can see the tumor above the liver background. This is a patient with lots of liver disease, but I can hardly see the tumors above the liver. So this is not really, PRRT in this kind of case is not the best option. It's not going to work as well, actually won't work at all, as compared to a case where you've got good uptake of gatate. So let's talk a little bit, before we get into how PRRT works, let's talk a little bit about how it's administered. So basically what happens is it's a day procedure. You would come into the hospital on the morning of the treatment or perhaps the night before. Obviously, there's a lot of workup that happens before we get to the PRRT point, and perhaps we can discuss that later. But we need to do certain blood tests to make sure that your bone marrow is working well, that your kidneys are working well, that your liver is working okay, so that we know that your body will tolerate the PRRT. We need to do the PET scanning. We need to show that your tumor is taking up PRRT. And then we also need to sometimes, and I know that this is often the frustrating part, sometimes we know that there's a tumor. We know that it's got gallium uptake. We know it will be good for PRRT, but we have to wait a bit before we treat, because we've got certain treatments and we've only got so many treatments. And if a tumor is stable and not growing and not compromising any other organ in your body. For example, compromising meaning it's so big that it's cutting off a bit of bowel and it's causing a bit of obstruction, those kind of things. If it's not doing that and it's fairly static and it's not growing, it's better to wait for it to start growing a little bit before we treat, for two reasons. Cells are more sensitive to radiation when they are growing. And the other reason is that when you do get PRRT, your body gets a radiation dose. So if you've got very little tumor, most of the dose or the treatment that we're giving is not going, it's going to the rest of the body. It's not actually doing anything. So it's sometimes really hard to have to wait, but sometimes it's better to wait. So if you get to the point where PRRT, the time is right for PRRT to be given, you would be contacted by the nuclear medicine PRRT team. They'll discuss it with you, discuss the advantages, the disadvantages, the side effects. We'll go through all of that, have the discussion with you. The oncology side and endocrinology, I'm not sure who of you've met Ben and Dragon and Veronica Boyle, also part of our team. They will also see you. We'll then make sure that you're properly prepared for the treatment in terms of your Octreotide, when you stop it, etc. I'll go through that a little bit later as well. But ultimately, you'll come into hospital and you will be, an IV drip will be placed into your arm, and then you will get some pre-medication. Pre-medication is ondansetron and dexamethasone to stop you from feeling nauseous. We then give an infusion, and this infusion here is called an amino acid infusion. Now, amino acids are given to protect the kidneys, and I'll go into a little bit more detail with that a little bit later. Because PRRT gets taken up by the kidney, we need to protect the kidneys, so we give an infusion of amino acids. We start that about 30 minutes before we give the PRRT. Once the amino acids is run for 30 minutes, Yasmin and Trish will come up with the dose. It's in a little lead-lined container because it's radioactive. They will then administer the dose of PRRT through the vein 30 minutes after the amino acids have started running, and the PRRT goes in typically over about 30 minutes. Then that gets taken away and the amino acid infusion continues for another 4 hours. And after that, 4 hours later, you will be checked, your radiation levels get checked by the medical physicist, and then you're able to go home. So that's just in a nutshell what happens on the day when you get your infusions of PRRT. So this is sort of just a timeline, and I'll go into a little bit more detail later, but you get an antiemetic, and then the amino acid infusion starts, and then the lutate gets given, or the PRRT gets given over 30 minutes, and then the amino acid infusion continues. Many people ask sort of, so how many cycles of treatment can I have? Generally, we would give you 4 cycles of PRRT. These are called induction cycles, and these are given 8 to 12 weeks apart. So you'll come up to Auckland every 8 to 12 weeks to come and have your PRRT cycles. And if you've finished with your cycles and you go back to your oncologist, and if your tumor then starts to grow again, we might go through the same process of doing another GATATE scan, having a look at your bloods, having a look at your bone marrow to see whether or not your tumor is still okay to be treated with PRRT? Has it still got the somatostatin receptors? So you could come back for what we call maintenance cycles of PRRT. And we actually have some patients who've had up to 18 cycles of PRRT. So it's not just that there are 4 cycles and that is the end of it. We basically will reevaluate as we walk the journey with you with your neuroendocrine tumor. And if you need more treatment and you're eligible and your body can tolerate it, then we will definitely give you some more maintenance treatment.
Rachelle, I'm just going to interrupt with a quick question from Karen in the chat, just asking, do patients ever miss the boat? By that she means that they've been suitable for PRRT, but they don't get it in a timely manner and then find that they're too ill to receive it. Does that ever happen?
What we do, and we haven't had a case like that here, because what we do is when the referral comes through for PRRT, the referral is received, and then we discuss it in our PRRT meeting, and we will then look at the risk of the disease. How quickly is it growing? Are there any organs that are at risk? Are there any sort of danger features that we need to be aware of? So how symptomatic is the patient? So there are different factors that we take into account, and we then generate, and this is the same, it's called a clinical risk score, and that is also similar score that is used at Peter Mac, to basically say that this is the type of tumor that really needs to be treated within 3 months. This is the type of tumor that can be treated within 6 months. And we would then stick to that. We know that the clinical score is, for example, needs to be treated, have a treatment window of 2 to 3 months, for example. If there isn't space on the waiting list and the patient needs to be treated, gets a date, but it's, for example, it's 4 months out as opposed to the 2 months out, communication gets sent out to the referring clinician to say that this tumor should be treated within 3 months. Unfortunately, there is a waiting list. We have a slot within 5 or 6 months, but if anything changes clinically, please contact us and we will reevaluate the situation. And if in that case, the clinician comes back, and we've had that, where they say, hang on a second, this tumor is now growing a little bit faster, or we'd still evaluate and see, is it still necessary to do treatment? But we would then try our very best to juggle around and try and bring a patient forward that's critical, if I can put it that way. But that's the best way we can manage it at the moment.
Thanks,
so
Rachelle. And Karen actually says, thank you. That will be very reassuring to many patients waiting for treatment.
Yeah. We've got a summary of every single patient that we've now generated. So with a associated risk score, and we monitor those patients quite carefully and try and stay on top of things. And it might be that nothing changes, and then it's okay to be treated in 4 or 5 months. It's not, if nothing changes, that 4 or 5 month period is fine. It's when something starts changing that we need to know, and we like to know, and we then would act on that. And that would generally come from the referring clinician saying, there's a problem here.
Thanks, Rachelle. That's fantastic.
Okie dokes. So how does PRRT work? So I've just given you sort of a little summary of how it's actually administered. So it really isn't a big thing. It's basically coming into the hospital, having the infusions, and then you can go home. It works a little bit differently to the gallium. So we had the gallium for the Gattate scan. That's what we did our imaging with. I'm going to take that gallium away and I'm going to swap it for something else called lutetium. And lutetium is the radioactive bit that you get with treatment. So you're not getting gallium, you're getting something different. But it's still stuck to dotatate, which likes the somatostatin receptor and will be taken up by the cell. So the lutetium is the radioactive bit, and it's slightly different to gallium in that it's got this little particle. Now this is probably going back to high school physics, isn't it? So this little particle is called a beta particle. And a beta particle is quite a special little particle. So it gets released from the lutetium. It's quite heavy. It's heavier than the imaging one that gets released with the gallium. So it can't travel very far. So once it gets onto the cell and gets into the cell, it basically says, oh, okay, I've moved far enough. I'm going to just stop here. And it stops. And it then releases all its energy. And it then, so it gets taken up by the cell. It goes into the cell. It then releases all its energy. And that is a DNA strand. We're all made of DNA. And that's what causes, helps cells to grow and regenerate, etc. It actually damages the DNA in the cell, and it then kills off the tumor cell. So that's how a beta particle that's stuck to the lutetium that we're treating you with does its job. The other thing that the lutetium has, it's also got a gamma ray. So it doesn't just have the beta ray. It's special, it's got both. So gamma ray means that we can do a scan after your treatment and have a look to see where the treatment has gone to in your body. So these are typically your post-therapy scans. So after each cycle, you'll come down to the nuclear medicine department. You don't go to Mercy for the post-treatment scan because it's a different isotope. It's lutetium. So we can image it down here in the department with our gamma cameras, and we'll do a scan after every single cycle that you have had. And the nice thing about doing the treatment scan is we can see where the tumor is in the body. Here it's in the liver, as well as in the region of the pancreas. And we can then see, okay, after my first cycle, look, my liver metastases are definitely better. I've still got the uptake in my pancreatic tumor. Becoming a little bit smaller, particularly this one, when I compare it to the previous ones. And in the end, after my cycle 4, there we go, it's a lot smaller. And even this little one's smaller too. So it gives us an idea of how well the treatment is working. And we will have a consultation with you after your treatment scan. So the treatment scan is done the next morning. So you get your lutetium infusion, your PRRT infusion. You'll then go home or stay over at Domain Lodge if you come from out of Auckland. And then the next morning you'll come into the hospital and we'll do the post-treatment scan, and we'll then discuss it with you. We'll show you the images and we'll go through it. An important thing that I want to just highlight is PRRT is not a treatment that can take a neuroendocrine tumor that's metastasized away completely. But it can shrink tumors, it can stop them from growing, and it can stop them from growing for quite some time, actually. So it just depends again on the makeup of your tumor, what type of cells it has, how aggressive it is, etc. So we generally we'd monitor you with the post-treatment cycles, and after your cycle 4, you will typically go back to your treating oncologist, and then 3 months after cycle 4, we'll do another GAT8 PET scan, which we'll compare to the scan you had before your treatment, and there we would be able to see how well the treatment has worked. Another interesting thing that I don't think people realize about PRRT, and one of the reasons why it works so well, is because lutetium has got a half-life, and it's got a half-life of 7.6 days. In other words, it takes 7.6 days for it to reduce to half of its amount. And if you look at medicines, you want 10 half-lives for something to be eliminated from your body. So if you do 10 half-lives, and if lutetium has a half-life of 7 days, it means it's approximately 70 days that it's still around, it's still doing something. So even though you wait between your treatments, 8, 12, sometimes 14 weeks, which is also okay, the lutetium is working during that period. And then you get your next cycle, and it keeps on working for that period. That's why our cycles are spaced so far apart. So it's not something that's given, and on the day it's there, it does a treatment, it leaves your body. It's actually working for quite some time afterwards. And that's one of the reasons it's so effective.
Rachelle, it's a good time for me to pop in with a quick question here,
Sure.
which relates to that. Cliff's asking, if you're not in Auckland and need to fly home, how soon after treatment can you do this, given that we're still radioactive after treatment?
That's a very, very good question. And we actually discussed this today. So basically, what will happen, and I've got a little slide about that later on, but what happens is, for you to be released back into the general public, you need to have a radiation level which is similar to background radiation. So we've got a medical physicist called Alan, and he will come in with a special little meter that can detect radiation, and he will then detect the radiation and do a measurement to see how radioactive are you. And he will then say, right, you are fine to go home. You can leave the lead-lined room. That's not a problem. But generally, we want people to wait 24 hours before they actually board a plane to get home. So you could, if your treatment happens on a Wednesday, you could book a flight for the Thursday afternoon. Because remember, you still have to come for your scan. That might take some time, and then you need to get to the airport. So we generally would say Thursday afternoon would be fine to fly home, and then you're safe.
Thank you. Sorry, I was trying to answer you and I was on mute.
No, it's fine. So is it painful when this PRRT kills the tumor cells? It sounds so aggressive, doesn't it? I mean, it's killing cells and DNA, and how does it make me feel? No, it's not painful. What it can cause is it can cause a little bit of inflammation, just like when you have a bruise, because the cell membranes are breaking and, you know, when you bump yourself. And for that, we give you the pre-medication called the dexamethasone. And that helps with the inflammation. And then the other thing that can happen is, because it damages the cell, as soon as the cell gets damaged or the DNA gets damaged, the cell dies, the cell membrane starts disintegrating, and then it releases hormones into your body. So sometimes if you've got a tumor that's a functional tumor, one of the things we need to be careful of when we give the PRRT is that there's a hormone, there may be a hormone release into your body, which make your symptoms slightly worse. And for that, we would prescribe some subcut Octreotide, which is nasty, but it helps with controlling those symptoms if you've got a very overactive tumor. But the majority of patients have none of these side effects and actually tolerate the treatment quite well. I can't see what that is because the Zoom thing is overlying it. But so the question was, what are the side effects and are there any side effects? So basically, the majority of patients, as I said, don't have any side effects. You might feel a little bit nauseous, and that's mainly because of the amino acid infusion. But for that, before we start your PRRT, we'll give you some ondansetron to help you with the nausea. Many patients feel tired, so don't underestimate it. You know, don't underestimate the effect that PRRT has in your body. You might feel a little bit sort of wiped out for a couple of days after, or just sleepy. So we recommend that you just go home and rest. You may get a temporary decrease in your blood counts. Remember, we're doing your bone marrow counts, we're doing your kidney counts. So sometimes the PRRT affects the bone marrow and you can have a decrease in the blood counts there. And for that reason, we check your bloods 2 weeks after your PRRT to make sure that your blood counts are still fine. And we also check it 2 weeks before you come for your next cycle of PRRT to make sure that your blood counts are fine. Typically, I say temporary. So the blood counts may drop, but invariably they recover again. It may take some time. If you've got a serious drop, you may have to postpone your treatments. How do I know that my platelets or my hemoglobin is going to drop? We don't know. We cannot predict. It's people have looked at this, and patients whose kidneys don't work as well or have got slightly reduced kidney function, they tend to have slight drops in bone marrow count sometimes. The one thing, and we've talked about this, is the kidney function. So PRRT does affect kidney function, but not to a huge extent. It's a little bit of function that drops off. Nothing so severe that you won't be able to survive without, they're going to drop off completely. We do give you some amino acids, and I'll show you how that works to protect the kidneys from the PRRT. And then in a very rare cases, about 2.5% of cases, very, very rarely, it affects the bone marrow so severely that it actually doesn't recover, and that gives you what we call a myelodysplastic syndrome. And that's one of the reasons also why we want to monitor your blood tests. Is the radiation dangerous to me or to my family? This is a question we often get. And the answer is no. And why is that? Because we're dealing with this little guy called a beta particle. And if you have a look, beta particles really don't travel very far in soft tissue. So they only travel about 2 millimeters. That's really not a huge amount. So the radiation is very localized. And that's the majority of the radiation with lutetium is the beta particle. And the gamma particles is not so abundant or frequent. And that's why our post-therapy images don't look as beautiful as the PET images, because there aren't that many gamma rays and it's not that dangerous. We do, however, take precautions. So after your treatment. So this is Alan, who I've told you about. He's the medical physicist. He'll come and visit you after your treatment, and that's his little radiation dose. It's called a Geiger counter, and that will count the amount of radiation that comes off you. And we've got Trish and Yasmin, and there's Jenny, who most of you or some of you may have met, who was part of the service earlier, or was part of setting it up. And during PRRT, we can't have any visitors. So they, unfortunately, because then we're dealing with the infusion, and that kind of makes sense. And then when you go home, we do have some radiation safety precautions, and all of you would receive a sheet which basically says, don't share a bed with one day with another adult, sleep separately from pregnant women, those sort of things. But they actually are quite easy guidelines to follow, and pretty straightforward. And you are pretty safe from a radiation point of view, and not endangering anybody else around you if you just follow these simple guidelines. Why do I have to stop my long-acting Octreotide before PRRT? That's a very good question. Because long-acting Octreotide also loves the somatostatin receptors. So it goes and it sits there, and because it's long-acting, it sits there for a very, very long time. And it then competes with the actual PRRT. So the PRRT don't have space to go and sit. So generally what we want is, we want you to stop your long-acting Octreotide, or time it, so that you have, it's 3 to 4 weeks after your injection. So I know Avril and Liana are very good with this, and they always say, when was your last Octreotide? We need to plan your GATAT scan and your PRRT. And I mentioned earlier about the fact that patients get a hormone release or are very symptomatic. What then? Because we've actually given patients some Octreotide while we do PRRT, or immediately before and then immediately after. And we then give you subcut Octreotide. So it's not the long-acting one, it's a short-acting one. And the short-acting one doesn't block the receptors for long enough. So we'll typically give it to you so that you stop it the night before, you have your PRRT infusion, and then after your PRRT infusion, you'll get your subcut Octreotide, and then you'll get your long-acting Octreotide. So to tide you over, if you've got symptoms and if things aren't, we're worried, we'll give you the subcut Octreotide, and that doesn't affect the actual effectiveness or the uptake of the PRRT. Why is PRRT sometimes given with chemotherapy? And I'm sure a lot of you have read about this, or heard, Peter Mac, I had PRRT and chemotherapy. How does that work? So the most common chemotherapy that is given with PRRT is temozolomide and capecitabine. And that's given with the PRRT. And basically how it works, you guys are experts now. We've got the beta particle that causes the damage to the DNA, and these types of chemotherapies also cause damage to the DNA. So they're called radiosensitizers. So that's almost like a double whammy. You get a, sort of an intense, killing of the DNA and cell death. So why isn't that our common practice? Why don't we do that all the time? Well, there's still a lot of research that needs to happen to find out exactly which type of patient would benefit from a combination treatment. It has been shown to be effective, but there's still a lot of questions around it. It's often harder for your body to handle combination treatments. The chemotherapy has got its own side effects. plus the PRRT, patients can get quite ill with that. And if combination therapies are considered, these should be carefully considered by your oncologist and the nuclear medicine physician. And they'll look at your images, they'll look at your type of tumor. They might actually decide, and this is mostly what we do, is we have a look at your tumor and we say, right, are we going to do chemotherapy first? Because it seems as though this tumor is growing a little bit too fast for PRRT, because you can get that. And then chemotherapy is perhaps better. And then we do PRRT. Might even do it the other way around. So we tend to sequence the treatments. Right, so how do these amino acids protect my kidneys? So if you have a look at the Gattate scan, look how much of the radiation actually goes to the kidneys. It's quite a bit, right? Because your kidneys actually take up the radiation. So these are the cells in your kidney, and the PRRT gets absorbed by the blood, and then it goes and it sticks because it's got receptors in your kidney, and it goes into the kidney cell and it actually damages the kidney. And what the amino acids do, and that's why we have to start them early, 30 minutes before we give you your PRRT, is they actually go and they block these little receptors so that the PRRT can't go and get stuck there. And then the PRRT gets excreted. And that's why if we give you the amino acids, your kidneys will be fine. You might have a little drop in kidney function, but it's something you wouldn't even think of or notice. So just to reiterate again, how are amino acids given? So they're generally given slowly over 4 hours, and they start at 30 minutes before PRRT. The amino acids are the things that might make you feel a little bit queasy, but we can just control the rate at which they go in, and we also give you the pre-meds. So I don't have great kidney function, so what, can I still have PRRT? So the answer is yes, but we will then ask that you need 2 more tests before we make that decision. And those tests are done in a nuclear medicine department. And the first one we do is called an isotope GFR. So all that really is it looks at how good your kidney is at eliminating things and how well it works. So that's the best way of checking if your kidney works, because a blood test can sometimes be a little bit inaccurate. That's the most accurate way of checking kidney function. And then we'll also send you for a kidney scan. And the kidney scan is also done in the nuclear medicine department. Both of these, the isotope GFR and the kidney scan, use tiny little bits of radiation to do the scan and the isotope GFR. You don't even have to go into any, it's just for the scan. You come in and you have the scans done, and then you go home. And we will then have a look at the kidney scan. The kidney scan, we want to make sure that the kidney is able to get rid of everything. There's no blockage. And the isotope is to see how well are the kidneys working, because there is a cutoff. There is a cutoff where if your kidneys are below this level, it becomes dangerous to give you PRRT. If it's above a certain level, we will still consider giving it, but we will be very, very careful, monitor you closely, and we will also perhaps reduce the dose that we give you, because as I said previously, patients with poor renal function sometimes get a higher dose to their bone marrow. But that's only if we go very, very low. But that'll all be discussed if need be. But just so that you are aware that you might be asked to go for more tests. And then that decision will be made. So my oncologist has sent me for an FDG PET scan. Now you've talked about Gattate PET scan. So what's an FDG PET scan, and why do I need to go for an FDG PET scan? And I can bet a lot of you have had FDG PET scans. So back to those 5 points that I spoke about in the beginning is the receptors. I said that the majority of neuroendocrine tumors have somatostatin receptors, but some of them don't. And growth. The majority of the tumors grow slow. Some grow a bit faster, but some tend to grow very fast. And it's generally in patients in whom we, sort of worry that they might not have receptors or tumors are growing very fast, that we would do an FDG PET scan. So how do we know? How do we know that you might need an FDG PET scan and a GAT8 PET scan? I'm sure you guys have all heard about this figure called a Chi-67, because doctors talk about it all the time. You've got a tumor and it's a Chi-67 of 10 or 5 or 3. What does this value actually mean? So a Chi-67 is basically just a marker to see how fast a tumor is growing, how fast a neuroendocrine tumor is growing. And when the surgeon took a biopsy of the tumor and gets sent off to the lab to have it tested to see what it is, they do this test. They have a look at the cells in the tumor, and they have a look. They stain it, and they see what the Chi-67 is. And Chi-67 can go from 0 all the way to 100%. And you might have, this puts the tumors into 3 different categories. A G1 tumor, which has a Chi-67 of less than 3%. A G or a grade 2 tumor, which has a Chi-67 of 3 to 20%. I'm not sure where you would fit. And then a grade 3 tumor, which has a Chi-67 of more than 20%. And most of these tumors, so these tumors grow slowly because they've got a Chi-67 of less than 3%. These tumors grow a bit faster because they've got a Chi-67 of 3 to 20%. And these tumors grow very fast because they've got a Chi-67 of more than 20%. And just to get back to that clinical risk score that we looked at, this is one of the things we look at as well, is we look carefully at the Chi-67 and see how is this tumor behaving. And these tumors typically have somatostatin receptors. These tumors may or may not have, or they may have a combination. They may have some cells which have got receptors, some cells which don't, and we need to know that. And these tumors generally don't have somatostatin receptors. And these are the tumors which don't have somatostatin receptors, which typically grow quite fast. And if you grow, and if you move a lot, and if you energize and you run around, you need a lot of sugar to keep you going, to keep the energy up. And FDG is a fluorine deoxyglucose. It's glucose, it's sugar. Sugar labeled to a radioactive particle. So it looks at cells that are using a lot of sugar to grow. And those are typically the more aggressive cells. So they use a lot of sugar and glucose. And these are the type of cells, type of tumors that we can clearly see on the FDG PET scan. And if you've got FDG, a lot of FDG uptake, which is more than the GAT8 uptake, which means your tumor is more aggressive than it has somatostatin receptors, we might say, right, perhaps chemo first, because chemotherapy works for more aggressive tumors, and then we'll deal with that part of the tumor, and then we'll do the PRRT later. Or we say PRRT is not a good idea. It's better to give to have chemo in this instance. So That's a G1 tumor, and G1 tumors, this image over here is a GAT8 image, and this is an FDG image. We know it's FDG because our brains are constantly working and need a lot of sugar to keep going. So you don't see any abnormal areas on the FDG, but you can see this tumor taking up a lot of the GAT8. This tumor is generally good for PRRT. PRRT is a good treatment option. In this instance, you've got a GAT8 image with a tumor, but you've also got some areas on the FDG scan that are taking up, which is telling us that tumor is a little bit more aggressive. But in this case, we need to carefully consider, what are the options? What's the best treatment? Should we start with chemo? Should we start with PRRT? How does it work? How do we sequence it? And this type of tumor generally doesn't have somatostatin receptors, so PRRT is not an option, but chemotherapy will be a better option. So those patients are generally not treated with PRRT. And I think that is more or less in a nutshell most of the questions that I get, and I hope I've been able to answer them.
That is absolutely fabulous, Rachelle. Absolutely fabulous. Now there are a couple of there's one more question in the chat that I think you'll be interested to answer, which is from Shiona asking, if you've got one type of neuroendocrine cancer, can you get another type of neuroendocrine cancer later on in life? So i.e., if you've got neuroendocrine cancer, are you predisposed to getting another type?
That's a very good question, and I don't entirely know the answer to that, to be quite honest. It's very rare. We don't really come across it, but there are genetic, sort of factors at play. But we don't see it generally. So I don't think it necessarily predisposes you to another, unless you've got a genetic abnormality which then predisposes you, for example, a MEN syndrome or something like that, where you get different neuroendocrine tumors.
Thanks, Rachelle. And Andy's made an interesting comment. He said that after PRRT, he experienced a strange sunburn-like experience, which was visible for about 24 hours and then disappeared.
Yes, that is something I didn't mention, actually. So it's called what we call a radiation flare. So it is radiation that we're giving you. Some people get it. You feel quite hot. One's face goes a bit red and it settles down. But it is something that does happen with the PRRT. The other thing that does happen, which I didn't mention, was some patients get a slight hair loss. So it's not like chemotherapy where all your hair falls out, but you might notice that, when you brush your hair, it's just thinning a little bit, but that generally resolves and nobody notices but you, because you're brushing your hair. So that's the other thing that can happen.
That's fantastic. Thank you. And then Liana's put a great little note for everyone in the chat that if you are coming to Auckland for PRRT, that the Auckland team helped organise transport if you're from out of town, so you don't have to pay for your transport or your accommodation. That's government funded as part of the service. So thanks, Liana, for that.
Can I just ask a question, Michelle?
Yes, please do.
It's Marge. I was just wondering, after PRRT, would I still get the carcinoid syndrome? Or does that reduce?
Can I answer that? Yes, we have PRRT is very effective in reducing carcinoid symptoms. It might not completely take it away, but a lot of patients experience, even sort of after their first or second cycles, a significant decrease in the amount of flushing and the amount of diarrhea. Obviously, it affects every patient differently. So it's difficult to predict, but generally, we would actually treat for patients with severe symptoms to see if we can help with that. So PRRT definitely does help.
Good. That's good to hear. Thank you.
Great, Michael here. I've got one quick question. Is it possible to get images that you can take away of the pre-treatment scan and the post-treatment?
That is absolutely 100% possible. And I think you should have them. You must just let us know, if we do the images, we discuss them with you, just say, listen, please give me a copy. It's the easiest thing to do. And
so I think we're so lucky that we've got Rachelle's medical experience in delivering PRRT, that we've got her enormous heart that she's leaving her family every fortnight to come and do this, and also that she's so clever and has that amazing gift of being able to communicate so clearly. So I've learned a lot tonight. I'm sure that you've all enjoyed it, and I just want to say a huge thank you to Rachelle from all of us.